Okay, good morning. My name's Dan Sucato. I'm currently the Chief of Staff here at Scottish Rite Hospital, and I've been here now 24 years, and I'm proud to give and honored to give this talk on scoliosis screening. I'm also the Director of the Center of Excellence for Spine Research, and we do a lot of clinical work as well as research. So my talk today is going to be on scoliosis screening and when to refer a patient. We're very proud of our relationship with our primary care providers, pediatricians, family medicine physicians, our advanced practice providers out there. And so we know you have a lot to see and know a lot about various things, including scoliosis. So we appreciate you. We love working with you. We love the referrals that you bring to the hospital. And if there's any questions for any of those patients, if you have any concerns, please do never hesitate to give us a call. We're always happy to get on the phone and speak with you about the patients that you refer here. So thank you. So my disclosures, I have a small relationship with Globus Medical. We developed a device here that is very good for patients' surgical procedures, and we get a small royalties for that. So the objective of this study, talk, is to discuss the causes and the classification of scoliosis in children and adolescents. To really look specifically, we have a nice video of how to screen patients, and you do this every day, and we'll just run through what we do here in terms of a physical exam, which will be very similar, if not exactly the same as what you do, and the things to look for, and then which appropriate imaging is necessary for each patient. We'll talk a little bit about treatment options, and treatment options have been pretty standard over the last 25, 30 years, but things are on the horizon. We'll talk about some of those things. We'll talk a little bit about some of the new ways we treat patients, as well as how we evaluate those patients. And then we'll talk really specifically about appropriate referrals for suspected scoliosis. And to be honest, the referrals that we get here today are always very appropriate. Even if a patient doesn't truly have scoliosis, but you're concerned about it, those patients we definitely want to see, because the vast majority of the time they have something that looks like scoliosis and may turn out to be scoliosis, maybe not that day, but with time and with growth, and we'll talk a little bit about that. So let me just give you a little perspective on Scottish Rite and the type of things that we do here with respect to scoliosis. And this is just some general numbers that we probably take care of as many children with spinal deformity, scoliosis, kyphoscoliosis, as any institution in the country and maybe even in the world. We have a very active orthotic program, and so most institutions have to send families out with a prescription for an orthotic, for a brace. But here we're very, very fortunate, very lucky to have an orthotics department here in the hospital. We have world-class orthotists that are right side by side with us in the clinic, and we're discussing when a brace is appropriate, which brace to use, how many hours a day, which curves we're going to brace. And so it's really a team effort. And I think that in a nutshell is what Scottish Rite is a team effort, that we have multiple people with multiple talent, with diverse skill sets, and we work together to do the very best for each and every patient we manage. We do many surgeries, and we try to avoid surgery with bracing, with other techniques, which we'll talk about today. So as I said, it's a multidisciplinary approach with many people involved in the care of patients and the evaluation of patients, from the ambulatory care nurses to the orthotists, certainly surgeons. Another special thing we have here is everything is in-house. And so, for example, our intraoperative spinal cord monitoring team is in-house. We don't outsource that to a third party. And these are folks that we work with each and every day. We actually, as surgeons, look at the monitoring, which is very unusual and a very good thing to make surgery safe, because that's the most important thing in surgery. And so, and we publish a lot on that spinal cord monitoring, as we do other things. Our anesthesiologists are all pediatric anesthesiologists. They don't do anything else. They do only orthopedics as an orthopedic institution. Our spine program, we really lean on our anesthesiologists to work in concert with us to make sure blood pressure is at the appropriate levels for various parts of the surgery to make surgery safe. We postoperatively have a pain management team that takes care of the patients. We have a full-time nurse that is solely dedicated to keeping children comfortable. We have really outstanding world-class respiratory therapists and also physical therapists that get involved in the care of these patients. Research is really the engine that drives decision-making. And so we look at all of the things that we do, and we try to do tomorrow better than what we're doing today. And the only way to do that is through research. And so we publish in many of the big, large journals today in orthopedics. And this is always to make patient care better. If there's questions, we have a great website that stays up to date on what we're doing in scoliosis and in spine deformity. And so we'll delve into the topic now. So scoliosis can be defined as a lateral curvature of the spine that's greater than 10 degrees on an x-ray. So if a child has an x-ray that shows a little bit of what we call spinal asymmetry, but the curve measures less than 10 degrees, then that's, or 10 degrees or less, we don't call that true scoliosis, but call it spinal asymmetry. And if the child is still growing, that can turn into scoliosis. So I try to, in a single slide, try to put what you need to know. And you need, this is all you really need to know about scoliosis. So the most important thing is to make a diagnosis. Like in any patient that you see, you need to make a diagnosis. Idiopathic scoliosis is by far the most common type of scoliosis we manage. And curves progress in two ways. Only in two ways. If they're still growing, so if the child is still growing, and we assess growth many, many ways, including their age, a number of physical characteristics, and then there's certainly radiographic characteristics, which we'll talk about. That's the first way. The second way curves get bigger is if the curve is greater than 50 degrees. Even if they're done growing, that curve will progress over time. And so those are the two main ways curves get bigger. You're still growing, or if the curve is above 50 degrees. So certainly if you have a young child who has a curve above 50 degrees, by both criteria, that curve will get bigger with time. For idiopathic scoliosis, meaning scoliosis where we don't know the cause, there's basically three types, and it's based on age, and we classify it that way. Infantile is from birth to 3 years of age. Juvenile is 4 to 10 years of age. And so for the young patients, the younger patients, because they have so much growth left, they're much more difficult to take care of because over time that curve growth is churning away, trying to make that curve get bigger. We oftentimes, or not oftentimes, for this patient group, we always get an MRI because there's about a 20% chance of having some neural axis abnormality in those patients who have juvenile or infantile scoliosis. And the treatment we'll talk about, there's many types of treatment. We use casting for the infantile and even the juvenile, and we'll show some results of that and why that's really important. And so early diagnosis for those patients is critically important. We use braces, we use growing rods, and then definitive fusion. We'll talk a little bit about those. Adolescent is certainly the most common type of scoliosis that we manage and that you see. The right thoracic curve is the most common type of curve pattern that we see. The treatment is either observing smaller curves less than 20 degrees. We brace curves between 20 degrees and 45 degrees, and anything above 45 and certainly 50 degrees, surgery is certainly entertained. Not always done, but certainly a very good indication for surgery, and other factors are taken into consideration. So those are the big highlights for idiopathic scoliosis. Well, let's talk a little bit about some details. So this is a young girl who first presented to us at 3 + 8 years of age, and so she has a left thoracic curve, and so you can see that on her images, her left scapula is a little bit more prominent. When she bends forward and does the Adams forward bend test, you can see the rotational deformity that she has, with the left side being a little bit higher than the right. And you can see that on the image when you look at her from the back as well as when you look at her from the side. So in a young patient like this, who's almost 4 years of age, she falls into the infantile idiopathic scoliosis. Her curve started before 3 years of age. She just happened to present to us at almost 4 years of age. So she had a very large curve. And you can see on this right film, these right films, that her curve, when you bend her to the left, the curve is relatively flexible. And so for this young patient, the question becomes, what's the next step? And so I'd like to give questions to sort of think about what is the next step. And so for an infantile or a juvenile idiopathic scoliosis patient, what is the next step? Is it an MRI of the spinal cord? Do we get a CT scan to understand the vertebral anomalies, ultrasound of the kidneys, or genetic screening of the family? And so for these patients who are less than 10, the incidence of having a neural axis abnormality, either a syrinx in the spinal cord, a tethered cord, a Chiari malformation, or a combination thereof, is about 20%. And so every patient that has infantile or juvenile scoliosis gets an MRI. Most patients with idiopathic scoliosis of the adolescent age group do not get an MRI, and we'll talk a little bit about that with time. So infantile scoliosis can be cured with early casting, true or false? And the answer is true. And so we are very aggressive with casting of young children, generally less than 2, but even in the older age group, to try to grow the spine straight. And then we've been very successful in doing that, and we'll show you some cases. So for this young girl, she was braced and she had some casting, but because she was a little bit older and the curve was bigger, our goal wasn't necessarily to grow her spine perfectly straight, because that would be very difficult, although we certainly try. But she was casted and braced intermittently for several years. And here she is at 15 years of age with a small curve, actually smaller than where she started, which is not typically seen for children with adolescent idiopathic scoliosis when we brace them. The goal of bracing is to really keep the curve in check so that it doesn't get bigger. Occasionally, with really good compliance, we do see some curve correction in children who have grown many years over time. So you can see she's got a very nice result. Here she is at 3 years of age, and with lots of growth, her curve really didn't change at all. She was very effectively treated in a brace. And again, this doesn't happen without great team approach, and so our orthotists were very heavily involved in the care of this patient, and she was very compliant with the brace. She was very active. She did a lot of gymnastics and sports, and so during those activities, she didn't wear a brace, but every time in bed when she's sleeping and during school, when she was not in PE, she wore a brace, and she was very effective, and she has a nice mobile back with a very small curve left, and she's done very well. So here's a 13-month-old. So a 13-month-old presents with infantile idiopathic scoliosis. And you can see this boy has a pretty good-sized curve. And so when they're young, though, and they have a lot of growth left, and the curve is relatively flexible, which most 13-month-old children are, then we put them in casts. And casting is, this is called Metacasting. Min Meta was a orthopedic surgeon who was in England. She's of Indian descent originally. We had her visit here in 2008, and she showed us her technique of casting. And so this is a typical cast, a Metacast. Oftentimes they go over the shoulders like this particular picture, but oftentimes they go under the shoulders, and the under the shoulder cast is a little bit better tolerated, but this is honestly very, very well tolerated by the children. The one it most affects is mom. So when you first put these on, the mom is really worried about it. But these children, they don't know any different, and they actually run, play, do everything. The cast can't get wet because there is soft cast padding underneath that's cotton, but otherwise they're running and playing and doing everything, and this honestly doesn't slow them down. So this young girl was put in that's her cast. So this boy, this is a patient of mine that I followed through the years, and we did several rounds of casting, and typically it's we do casting, and the casts stay on for about 3 months at a time. We change it at 3 months, and we try to do about almost a year of casting. So somewhere about 4 to 5 casts, and then that's what we did for this young boy. And then they don't generally they either go into a brace if they still have residual curve, or if the curve is pretty straight like this young boy, we just watch them over time. And here he is at 11 years of age, and his spine is perfectly straight. So this boy had about a 9 to 10 month period of casting, and then after his cast came off, we followed him, and he's done beautifully without any other treatment. So sometimes children present to us in that less than 10-year age group, infantile or juvenile scoliosis, with larger, stiffer curves. So here's a young girl who is 4 years of age, and so she has a larger curve, and so she has growing rods. And the concept behind growing rods is that you place the rods, you seat them proximally and distally, and then over time, as they're growing, the rods are lengthened. And the traditional growing rods, which we've been doing for many, many years, is where you put the rods in, and then every 6 months or so, you do a small lengthening, which is a small operative procedure. So they go under anesthesia. They're here for just a day, and then they go home, usually on that same day as a day surgery. And so here's a young patient of mine that over the years we used growing rods, and then she, at the end, had a definitive fusion where we actually did the fusion procedure where all those elements that we operate on become one bone. This magic rod came on the scene about 5-6 years ago, and actually a little bit even longer than that. And so same concept. This is a growing rod. The difference is that these rods go in, and then the lengthening, so small procedures, the patient does not need to go to the operating room, and that we use this device that communicates with the center portion of these rods, and then it tells the rod to grow a few millimeters each time you do it. And so they can just come to the clinic or to the office, and as you can see here, the patient lies prone. You put this device over them. It doesn't hurt, and it just distracts each of those two rods 3 to 4 millimeters at a time, and that does the lengthening. So this has been very, very good. It's not the panacea. It doesn't take care of every patient because it only can distract a little. It doesn't distract with as much force as you can when you're doing a traditional growing rod, but seems to work pretty well. And so here's a young patient, 5.5 years old, with a pretty good sized curve. And you can see this is June of 2014, and you can see that over time, this patient was lengthened over about a year period of time, and they're continuing on lengthenings. We don't have current x-rays, but as you blow up on this, you can see that the amount of length here over that period of time was about 2 centimeters. So you can see that there's a male and female component to this rod, and then it lengthens over time. And again, we do that in the clinic. So we do this. We probably have the largest group of patients who are undergoing magic rods here in the United States. And so that experience has worked out very well, and we continue to look at that. So the key points for infantile and juvenile idiopathic scoliosis are to make a diagnosis. And so idiopathic scoliosis is a diagnosis of exclusion. So we're looking for underlying neuromuscular conditions, congenital abnormalities of the bones. If we don't see any of that, then these are otherwise known as idiopathic scoliosis. And oftentimes in the young patients, as they're holding their baby, their moms often feel the bump or the prominence on their back. And if they say that, I believe them. And so that's a very important thing. It's not only the x-rays, but also what is the clinical appearance of the child. And so if the child has a prominence that looks like scoliosis, but the curve looks relatively small, I generally watch those children very closely because it's generally those curves will get bigger over time and will need treatment. The Adams-Ford bend test, which we're going to go over in a video very shortly here, and then the standing x-rays are important. Early treatment is ideal. The sooner we can get to curves, the better chance we have in infantile idiopathic scoliosis to grow them straight. So if you have a baby, if any concerns, they have scoliosis, please refer them. The sooner we get to them and make a diagnosis, either scoliosis or not, the better it is for the child. Because if they do have scoliosis and we think it needs treatment, then we can get that spine to grow straight, and hopefully they don't need any other treatment ever. So bracing and casting, and so casting is done in the infantile, bracing typically for the juvenile, and then if necessary, growing rods. And the MRI of the spinal cord is critically important. So now let's switch to the physical exam. So this is a young adolescent girl who presented to us, and you can see this video is going to show a good physical exam. So as you look at her from the back, we always like to have them sort of with their feet shoulder width apart, their arms sort of relaxed at their sides, as you can see here. A sports bra would be great in young ladies. We have a gown here that we use that keeps them covered in the front, and we can see their back in a very easy way. So the first thing we look at, and this is a longer video, but this takes a very short period of time to do the physical exam, is to look at their shoulder heights. And so if you look here on this young lady, you can see at the tip of her shoulder on the right compared to the left, you could argue that the right shoulder is a little bit elevated compared to the left shoulder. If you get a little bit closer in the trapezial area, you can also see that the right shoulder looks probably a little bit taller, a little bit higher than the left side, but nothing too obvious. And then the next thing we look at is the shoulder blades. And since thoracic curves are the most common type of scoliosis we see, you will oftentimes see the scapula a little bit more prominent on one side compared to the other. So here you can see that the scapula, the shoulder blade on the right, looks a little bit more prominent than that on the left. And so we look at that. The next is to look at where their body is relative to their pelvis. So if you look at their trunk and you look at where their pelvis is, we're trying to see if there's a shift to the right or to the left. And here on this young girl, there's probably a little bit of shift to the right on her compared to the left. The next thing we look at is the waistline. And so you can see on the left, there's a little bit of a waistline difference than the right. The right looks a little bit more curved than the left. If you look at where her arms are relative to her waist, it looks like her left arm is closer at her side than her right side. And as I say that, she kind of moved her arms in response to me saying that. And so you can see that that would indicate she has a little bit more of a shift to the right, and she has a little bit of waistline asymmetry. So that's a quick view. You look at the shoulder height, look at the shoulder blade, see where her trunk is, and then look at her waistline and see if there's a difference. And then really the ultimate test is when the children bend forward, and that's the Adams forward bend test. So as she bends forward, it becomes a lot more clear that she has a right thoracic scoliosis. And so here, what you're really looking at is the rotational aspect of scoliosis. And scoliosis is defined as a lateral curvature right to left, but really in concert with that is a rotational deformity. So as she bends forward, the rotational aspect of the scoliosis is clearly evident. And so this is really where it's important to do the forward bend test. And so you can see that the right side is higher than the left side, and so she has a right thoracic scoliosis. And then the next question is, does she have a lumbar curve? And it's a little bit more difficult to see here as she's bent forward, but it may be that she has a little bit of a lumbar prominence. And sometimes it's good to just feel that in addition to looking at it. Then the other option is to turn them to the side and see what they look like as they turn to the side to see if that lumbar prominence is present. So as she bends forward, you can see that right thoracic prominence. And then you can use the scoliometer. So the scoliometer measures the rotational aspect of the scoliosis. And so you want to put this center aspect over her spinous processes. So you can feel those or see those on her. She's thin. And then this is just tilted up in a way that would identify how much rotation she has. And you can see that the ball there is up close to 15 degrees. And so you just get the largest measurement, and you're typically doing this at the apex of the curve. So for right thoracic scoliosis, you're going to just move it up and down until you see the biggest number. The typical referral number for the rotational aspect of the scoliosis is 7 degrees or more. So a 7-degree rotational deformity would be a good indication. As you saw there in the lumbar spine, it was 7 degrees. Anything greater than that, or 7 degrees or greater, would be a good indication for a referral. Now, a 20-degree curve typically, a 7-degree rotational curve on the Adams forward bend test typically is consistent with a 20-degree X-ray appearance of scoliosis. So remember, the X-ray is a little bit different than the rotational aspect of scoliosis. And so that's why we typically pick 7 degrees. I would also say, though, that you don't need to use a scoliometer. Your clinical judgment is what you should use. If you see any rotational deformity, especially in a child who you think is growing, and even if they're not, if you have any suspicion for scoliosis, we would be happy to see those patients. Whether you X-ray them or not, we will talk about here in a second. But you saw there on that last part of that video that you could see her lumbar prominence, which was shown when you turn her to her right. And you could either see that or feel it with your hands on top of her back and sense whether she has a rotational deformity. Okay, so here's some questions for adolescent idiopathic scoliosis. What are the common features? So is it more common in males or females? Is a right curve or a left thoracic curve more common? And is it painful? And so the answer is scoliosis for larger curves is more common in girls than it is in boys. For very small curves, boys and girls are similar actually in terms of the incidence. By far, the most common curve is a right thoracic scoliosis for idiopathic scoliosis. And in fact, if we see a left thoracic curve, then we're really suspicious that a neural axis abnormality is present. So we do good physical exam, which we'll talk about here in a second, and then we'll always get an MRI for a primary left thoracic scoliosis. And are curves painful? And this is evolving through the years, but typically we don't think that scoliosis in the adolescent or infantile or juvenile period is painful, is it oftentimes associated with pain? The answer is yes. A large study that came from this institution, which 3,000 children who had scoliosis were looked at, and the incidence of back pain was 30% in those children. Unfortunately, a comparative study wasn't done at the time, but I would suspect that if you questioned 3,000 adolescents who did not have scoliosis, that the likelihood is that they would have probably close to 20, 25, maybe even 30% having some back pain. So children with scoliosis, with or without scoliosis, who have back pain, we have a very specific protocol for physical therapy and getting them on the right track. But there's no question that this is a perception that scoliosis causes back pain. We think it's associated with back pain, but not a true cause of back pain in the adolescent age group. So here's another question, the indication and goal of bracing. So what are the indications for bracing? The indications for bracing are for curves between 20 and 45 degrees. And the goal of bracing, as I mentioned earlier, is to prevent that curve from getting bigger with time. It generally doesn't improve the curve, and that's a very common question that we have from families. Having said that, for children who are incredibly compliant with the brace, who are wearing it during their very, very fast growth spurt, we oftentimes will see some improvement or permanent improvement in their curve if they wear that brace very well over time. So here's a young girl, 10 plus 5, who presents with this mild, moderate curve. And since a 10-and-a-half-year-old child is growing very fast, there's no question with this curve magnitude that this child will go into a brace. So she is very young. You can see that her triradiate cartilage is open. That's the growth plate of the hip socket. And so we know she's growing fast, and we'll talk a little bit about those growth parameters. So we typically, again, when we see a child who we think needs to be in a brace, we're with our orthotist in the clinic, and we'll talk about the type of brace that we wear, that the child should wear. So typically, we have two main types of braces, the all-day and nighttime brace and the nighttime brace. Now, there's variations within those two broad categories. The TLSO, or thoracic lumbar, TLSO is thoracic lumbar sacral orthosis, is the most common type of scoliosis, and it's a Boston brace has been traditionally the brace that we've used. But there are other braces that we're using today. They're all custom made to each child, and we'll talk about that a little bit here in a second. But we take a laser optic scan of the child at the time of that visit, and then the orthotist makes the brace custom made to that patient. We use CAD/CAM technology down in the orthotics department, and so this brace is custom made for the child. They have a separate appointment with the orthotist a month after they see us together to have a fitting of the brace, and they're given the T-shirts, they're given all the education they need for the brace. They're shown how to use the brace, how tight to have the brace, and then at that visit, they're given all the information that they need. They go home and then they wear the brace and try to get up on the hours that they need to wear the brace, and then we see them a month after that. So 2 months after our initial visit, when we prescribe the brace, we see them after they've had their brace for a month, and then we get an x-ray in the brace, and that's what this image shows. And you can see the amount of correction that is nicely achieved in the brace. So when the child's in the brace, the curve is corrected so that as they grow, the curve doesn't get any bigger over time. At this visit, we also let them know, and we've let them know when they got their brace, that we have a temperature sensor in the brace. So the temperature sensor pings the brace every 15 minutes, and it looks to see if the patient's wearing the brace. And so we give them a sort of report card to see how they're doing with respect to the brace. And in the beginning, it takes a little while for them to get ramped up in terms of the number of hours that they need to wear the brace, and then we give them a goal to hit, roughly, and then we get a report card back to say, you're meeting that goal or you're having some trouble here and there, and so we strategize and try to make sure that we can get them to wear the brace the number of hours that they need. So the other thing that we have here is something called the Brace Rite app, which is actually a real-time app that the children and the parents are using to see on a day-to-day basis how they're wearing the brace. So instead of coming back at 3 months and waiting for the report card, they can actually see how many hours they're wearing it each day. And that's something that was developed here and that has been very, very useful in making sure that patients understand what they're wearing. And for those who have used it, they've been very, very happy with that Brace Rite app. So here you can see over time the patient has grown a lot, and you can see that the brace is held in check so that when they're done growing, the curve is still where they were when they were 10 years of age, and they've done very well and no evidence of curve progression. So that's a big success. And a child like this who's done growing, who has this 35-ish degree curve, that curve is never going to progress over time and will never cause them any difficulties. And there's long-term studies to look at that. There's a 50-year study that looked at children like this, and there was no difference between those patients who had scoliosis at 65 years of age and those patients who didn't have scoliosis. The only difference they found was a little bit more back pain in the patients who had scoliosis compared to those who didn't. And they were more cosmetically concerned with their back than those patients that didn't have scoliosis. But you have to remember that in that study, they had curves. This was a small curve for that study. Many of those curves were very large because treatment was never undertaken in those particular patients. So the scoliometer we talked about was introduced in 1984. It's really a quantitative way to measure the rotational aspect of scoliosis. And again, 7 degrees is the typical patients that we need to refer. And so any child who's immature in terms of their skeletal immaturity and has a 7-degree curve, we will have those patients referred here. Screening physical exam we talked about, so these are the many things that we look at. These are all patients who've had surgical treatment. So obviously this young lady on their left, she has a big body shift to the right. You can see she has significant waistline asymmetry with that left side more curved than the right side. And so that's a very clear, large curve. The young lady all the way to the right has the opposite sort of curve. She has a little bit more waistline asymmetry on the right with a little waistline curve on the on the right side and straighter on the left side. And she has a little body shift to the left. The young lady in the middle actually has balanced curves. So she has a large thoracic curve, which you can see her scapula is more prominent, her shoulders elevated on that right side, and she has a lumbar curve with some waistline asymmetry. But overall, she's in good balance because both the right and the left curve balance each other. But she was a curve that was in the 60-degree range and required surgical treatment. So those are the things we look at on physical exam. And then the Adams-Ford bend test is very useful. So here's a young boy with, again, balanced curve. So when you look at him from behind, he doesn't have a large trunk shift to one side or the other. His scapula is prominent on the right side. His shoulder is actually elevated on the left side. And he has some waistline asymmetry with his right waist more curved than his left side. When he bends forward, however, you can see on that top picture, you can see his lumbar prominence. And on the bottom right picture, you can see both the lumbar prominence as well as the thoracic prominence. So the Adams-Ford bend test is really important. And this test should take very little time, and you all do it, and you all do it very well. So standing, just getting a sense of where they are in terms of their shoulder height, scapula, trunk shift, waistline asymmetry, bending them forward, and then either seeing or feeling or both any rotational aspect of the curve that you may see. So again, presenting complaints for idiopathic scoliosis, we oftentimes, again, see patients with pain. Again, we don't think scoliosis causes pain, so we typically say pain is not caused by scoliosis. Respiratory complaints, children, unless they have very, very large curves, are never going to complain of respiratory issues. They have to be curves above 80 degrees, and even those curves are curves that we will test pulmonary function and we'll see a difference, but the patient doesn't feel any difference in terms of shortness of breath. Neurologic deficit for idiopathic scoliosis, no, they don't have any neurologic deficit, no weakness, no bowel or bladder issues. And cosmetic concerns, absolutely, they do have cosmetic concerns. So on our physical exam, we like to, again, look at their back. We look for skin changes. So children, we want to make a diagnosis of idiopathic scoliosis. It's a diagnosis of exclusion. And so if they have skin lesions like cafe au lait spots for neurofibromatosis, that certainly makes that diagnosis. Iliac crests, again, we're looking for limb length discrepancy. So oftentimes a child will have a little bit of a scoliosis or apparent scoliosis, but when they're standing with their feet shoulder width apart and you put your fingers on the top of the iliac crest, you might notice one iliac crest a little bit higher than the other. And that's really the best way to test limb length discrepancy. And so measuring from the anterior superior iliac spine to the medial malleolus supine on the table is not a very accurate way to do it. The easiest and fastest way is to have them stand with their feet shoulder width apart, put your fingers on the top of their iliac crest and see if they're even. If they're not even, if you have a block, or you can put something under their short leg to see how much it would take to even them out, and then examine them again, that's another tool or trick to see if they truly have scoliosis or if it's just a little bit of a leg length discrepancy. Again, if there's any concerns, a referral is appropriate. Again, we're looking for spinal balance. We're looking for asymmetry anteriorly, so you can look at patients from the front, but it's very difficult to do that just from trying to keep the exam comfortable to the family and to the patient. So who should be referred? And this is probably a really important aspect that I think you want some guidance on. And I'd say that just in general, if you have any concern, if you think they have scoliosis, you're right 100% of the time, and those patients should be referred. So clearly the patient on the left who has no scoliosis on an x-ray doesn't need referral for scoliosis. They may have back pain, and we're happy to take care of those patients for sure. And the patient on the right, clearly, who has an x-ray that demonstrates big scoliosis, needs referred. And what about the patient in the middle with a mild scoliosis? So at the outset, I would say that today, and we'll talk about how x-rays are done, if you have any question about scoliosis, it's almost better to refer them here, because we'll obtain an x-ray if we think it's appropriate, and in that scenario it's probably appropriate. And we do it in a way that gives us really a good quality x-ray with incredibly low radiation. We'll talk about the technology that we have here, not only in our main, in the Dallas campus, but also on the Frisco campus. And so that's, and we'll talk a little bit about that technology. So again, there's two things that make curves get bigger. One is if they're still growing, and the second is if the curve is above 50 degrees. So how do we assess remaining growth? And there's many ways. So in young ladies, we look at their menarchal status. When have they started to have a fairly consistent menstrual period? Generally speaking, once girls have their menstrual period, generally speaking, 18 months to 2 years after that is when their spine is done growing. Now, obviously, that changes with their activities, and that may be a little bit of an outlier in terms of the menarchal status. We look also at something called the Risser sign. So the Risser sign is on the same x-ray that we get with the spine x-ray, because their pelvis is included. And that is a sign that we've been using for many, many years. That's a scale that goes from 0 to 5. The smaller the number, the more growth you have remaining. And so a Risser 0 means that you have no ossification, no bone on the top of the iliac crest. And that means you're growing very fast. If the triradiate cartilage of the hip socket is open, that's the growth plate of the hip socket, if that's open, you're really churning away at growth. You're growing fast. A Risser 1 starts on the lateral aspect, and then we've depicted this in green. And so you'll see some bone line on the top part of the iliac crest, and that's on the most lateral aspect. If it's halfway across, it's Risser 2. If it's 3/4 of the way across, it's Risser 3. And all the way across, it's Risser 4. Risser 5 means that that bone has fused to the rest of the iliac crest. So here's a picture that shows the Risser sign. And in this particular patient, this white line of bone comes all the way across, and therefore it's a Risser 4. But it has not fused, because you can see the black between that white line and the rest of the iliac crest that has not fused to the rest of the iliac crest. So that's one thing. Today, and in the last 5 years, we actually use other techniques. And so on that plain x-ray, we're also using the proximal humerus growth plate, and that's called the proximal humeral ossification system, and that's a 5-part system, a little bit different than the Risser 5-part system, but the same concept. The smaller the number, the more growth you have left. So we use that. We're also using a hand film. So the Sanders classification is used, and that's an 8-part classification system. And these are 3 systems that we use for the patients to understand how much growth they have remaining. We don't get a hand film on every patient, because that's an extra x-ray, but we use it quite a bit, especially when we're making big decisions about bracing, when to start the brace, if to start the brace, and when to finish bracing. Again, remember, we start bracing in curves that are still growing in children whose curves are 20 to 45 degrees, and we stop bracing when the children we think are done growing in their spine. So these films are very important for those. The first 2, the Risser sign and the proximal humerus, can be obtained on the spine x-ray. The hand film is an extra x-ray that's necessary. And then what we're really looking for is peak height velocity. So in this graph, it's PHV. And so peak height velocity is where the children are growing the fastest. And so typically, the fastest children grow is about, in boys and girls, it's a little bit different in boys and girls, but just roughly they grow about 10 centimeters per year at their fastest peak height. And so if we've seen a child 6 months ago, and then we see them in 6 months, and we measure their height every time they come to the hospital, and they've grown 3 centimeters over that 6 months, then they're growing at a 6 centimeter a year pace. And so that child is not in their peak height velocity. They're either before that or they're after that. But if they're 10 centimeters or roughly close to 10 centimeters, then they're probably in their peak height velocity. So that's very important for us to know. That is the most important time to wear the brace, when they're really going very, very fast. And so you can see where the Risser sign is relative to peak height velocity. And so the first time we see a Risser 1, they're past their peak height velocity. And so the Risser sign, that's the limitation of it, because you're Risser 0 from birth until you're Risser 1. And during that time, you're in your peak height velocity. And so you don't know exactly where it is. And so that's where the humerus and the Sanders classification are very useful to us. So if you think about treatment choices today and traditionally, we've had basically 3 types of management for idiopathic scoliosis. So for patient, and it's based primarily on curve size, and it's based on how much growth remaining. And so this just lists the Risser stage, but we also use, again, the humerus and the hand staging system. And so in children who have curves less than 20 degrees, the vast majority of those patients, we're just going to keep a close eye on them, especially if they're growing fast. If we see, and you may see that a patient of yours that you referred in started bracing even at 18 or 19 degrees, it depends on many things, including the curve magnitude. But if we can see a lumbar curve in a child who's got a lot of growth left and has an 18 or 19 degree curve or 17 degree curve, some of us will start bracing, because for lumbar curves, we can use a nighttime brace. And so a nighttime brace is a lot easier to wear, obviously, than an all-day and nighttime brace. And so if we can get on that curve early, then we have a better chance of that curve not progressing to the surgical magnitude, which is ultimately the goal. But also ultimately, it's try to keep that curve as small as you can, especially lumbar curves where most of your motion is, and you need a very healthy spine the rest of your life to function well. So, but typically less than 20 degrees we watch. Between 20 and 45 degrees in children who are growing, we use a brace. So oftentimes the question comes up, well, what if a child's not growing and their curve is between 20 and 45 degrees? Those children are not, their curve is not going to get bigger because they're growing, and so there's no need for a brace. Could they get bigger just because the curve is so big, especially as they get close to 50 degrees? Yes, no question, but a brace will not prevent that patient's curve from getting worse. So if you're done growing, or if you're past your real peak height velocity, a brace is not necessary or is appropriate. So that's why between 20 and 45 degrees, if you're a Risser up to a Risser 2, then we will brace those children. If you're a Risser 3, 4, or 5, you don't have enough remaining growth really to have any advantage to using a brace. If we have a child who's a Risser 3 to 5, and we have any question that they're still growing, they're 3 to 5, but they look like they just have a growth spurt that's coming up, then we'll get a hand film, and we'll also certainly look at the proximal humerus. And we have a low threshold to take the youngest age, skeletal age that we see, so that we're not missing an opportunity to brace a child. So if somebody's a Risser 3, but they're a Sanders 2 or 3, we're certainly going to brace those children because we don't want that curve to get bigger. Generally speaking, above 45, and really we're pretty conservative, so it really has to be above 50 degrees before we really start talking about surgery. However, if a patient has a 45-degree curve and they're Risser 0, they're very young, we know that curve has a 100% chance of progressing over time, and so surgery is entertained at that point. There's many factors that go into the decision for surgery, and the surgical indications are based on many things, including how the child looks, how big the curve is, how balanced they are. So a single thoracic curve that shifts the child to the right that's 51 degrees is going to want surgery every time because they can see that their body shifted and surgery corrects that. A well-balanced 50-degree curve in a child who's done growing, may not progress with time, and we may watch them, especially if they want to watch it, because otherwise surgery goes down into the lumbar spine, and we don't necessarily make a decision at that time to move forward with surgery. So let's talk about bracing again. So the indications we talked about, the goal is to prevent progression to surgical range, and it's dose dependent. The more you wear the brace, the more effective it is. And we know that we have some of the most landmark studies done at this institution because we started using a temperature sensor years ago, and so we have really good data on the compliance. And no question that the more you wear the brace, the more effective it is. So a young child who has a lot of growth left, who has a pretty big curve, will really push them to wear that brace 18, 20, and maybe even 22 hours a day, whereas a child who has a smaller curve that doesn't have as much growth remaining will be more in that 18 to 20 hour range, and even maybe even a little bit lower than that. And so you can see some studies which have been published. There was a large study that was funded by the NIH. That was a multi-institution study that really proved that bracing works. Some people never thought that bracing works, but its success rate was 75%, 75 to 85%. This brace wear study that you see to the right was published at our institution, and again, shows that it's dose dependent. The more you wear it, the more successful it is. Daytime hours turned out to be a little bit better than nighttime hours. So again, we have an orthotist in the clinic with us. It's sort of shared decision-making between the surgeon, the orthotist, and of course the family. We make all of our braces in-house, and it's very, very successful. We're so proud of the orthotists and the team that we have, and it's a team effort that makes the bracing successful, and it's worked very well for us. So here's two main types of braces: a daytime brace, which you see there to the left, and the nighttime brace, which you see there to the right. And the nighttime brace actually overcorrects the curve a little bit, and you can sleep in that. You obviously can't get around with a curve, with a brace that makes you curve in the opposite direction. But both braces are successful. Depends on the curve type, the age of the patient, and other factors to decide whether we can use a nighttime brace. We certainly like to use a nighttime brace as much as we can for most patients. And we're using nighttime braces more and more because we're more effective with our bracing. So just to talk about a couple things that you will be hearing about or you have already heard about. So vertebral body tethering is a technique that has been sort of in development for many years. I think it's still a little bit investigational, but the data is becoming clearer on certain effectiveness of the brace, of the vertebral body tethering, as well as some of the complications that can occur. We are approved to do this. We are doing vertebral body tethering for select patients. The indications are for children somewhere between 30 and 60 degrees, and think about the vertebral body tethering like an internal brace. For those children that don't wear the brace, for those children that aren't indicated for the brace, vertebral body tethering is an option, and it keeps the spine mobile, but also tries to grow the spine straighter. And so this is an indication, and we're happy to talk about the details of that. Here is a patient that had vertebral body tethering. You can see the curve to the left. And over time, when you put the vertebral body tethering device in, over time, the brace, the internal brace, or the VBT, allows that curve to improve over time. And you can see at the end of 5 years, the curve is better. And the nice thing about this, it also maintains the stability the flexibility of the patient's spine. This is the more severe curves that we take care of, and this is not amenable to VBT and is the more traditional method. And you can see that we can correct spines and get them pretty straight today with the techniques that we use. Unfortunately, you have to fuse the spine, but these children function very well. They get back to all their activities without any restrictions whatsoever. Spinal cord monitoring is critically important for us. And again, we do this all in-house. And so this is an advantage that we have that keeps our patients safe. So neurologic issues are the biggest concern we have. And we've been incredibly safe because we have our own team in the operating room with us. Here's that young girl before who had a big curve. And you can see that she's got nice correction of her scoliosis with the traditional posterior spinal fusion and instrumentation. This is what's new and good for patients. So this is how we image patients today for scoliosis. So here on the Dallas and the Frisco campus, all of our children who have scoliosis get this type of imaging. This is the EOS system. The most important thing is for families, it's low-dose radiation. But we're able to do a 3D reconstruction of the patient. We get the front view and the side view at the same time. It's a pretty cool machine, too. It's got a little light that goes down and shows the children where we're x-raying them, and that works very, very well. So, in conclusion, always obtain a good history and physical. The standing exam, which we talked about a lot, is really important. Adams Ford Bend test is critically important. Refer if there's any concern. If you want to use a scoliometer, you can use it, but your clinical skills will tell you which way to go. And early detection is obviously important. We want to provide the opportunity for non-operative treatment, bracing, casting, and that gives us the opportunity to avoid the next step, which is surgical treatment. So thanks for your attention. Thank you again for all you do. If there's any questions that come up, please don't hesitate to contact us. We'd be happy to chat at any time. Have a great day. Thank you.